you very much. It's a real pleasure and honor for me to be here and share a little of the experience that we have been doing with Basic Health International in El Salvador and other countries. I'm very happy to be here to see Sadeep and Stella, good friends from a long time. So I'm going to talk a little about a model that I've been working on. It's called Preventable. It's more of a multi-steps to think of when you're thinking of cancer implementation in low and middle income countries. I have to say I have no commercial relationship with any entity that sells or produces products related to HPV. So a little of the organization that I work with, it's called Basic Health International. Our vision is to live in a world where no woman should die of cervical cancer because this is a completely preventable disease. Our mission is to eradicate cervical cancer globally. These are some of the countries that we have visited throughout the years. We have worked on, consulted, sometimes just visited to learn from them. We know that programs are different everywhere, so we're trying to learn from them. We're trying to share our experiences. We know that every country is different. There's no one single solution for implementation in these settings, but a lot of the challenges are very, very similar when we find ourselves in low and middle income countries. I'm going to talk a little about the implementation side. Obviously, there's research involved, and according to the NIH, implementation is the process of putting to use or integrating evidence-based interventions within a setting. And this is the blue highways, the NIH roadmap, that it goes from all the way from the bench testing to the actual translation to the population, and it's quite a process to go through. And you know, this is something that I talk about in all my talks. There's the ideal world, then there's the practical side of it, and then there's the real world. And the ideal world is when we have our, like an example is we have a research project and we have all the funding that we need the personnel that, you know, that we need to actually make the project. But then when we finish the project or the funds go away, then we start to struggle with, you know, practically, can we actually make this happen or not? And in reality, a lot of what ideally was what we thought a good idea, in reality, it can't happen. So when we have limited resources, we have to try to find the balance between the ideal and the real as we think about that. And the same goes to policy. And these are some pictures from like the last 10 years. I don't even recognize myself in some of them when I look at that. But it's really important to understand when we're thinking of programs, like the actual field work, you know, what it takes to get things happening. And because sometimes when you're thinking of policy, you kind of forget, you know, that the decisions that you're making are going to affect the people on the field. And if you're not really conscious of how hard things are to get done, you're gonna try to apply policies that just won't work. So it's really important for the implementation. So talking a little of the background of the problem that I'm here to talk to you, it's you know, the problem is cervical cancer. We know that this is global can information. We know it's like the third cause prevalence in the world for women's cancer. If we go to Latin America, it's the second one, and if we go to El Salvador, which is the country where I'm from, it's the #1 cause of mortality due to cancer, according to the registrations that we have. And that's global can. A lot of it's based on estimates, and this is the Ministry of Health did an assessment from 2009 and 2013, and that reinforced that cervical cancer was the leading cause of death of cancer of women. So we all know that this is caused because of the human papillomavirus. And just in case you don't know a lot of the natural history, I'll just go through this very quickly. But we know that this is basically due to HPV. We know that most of the HPV will not progress to pre-cancer and cancer, but because most of it will have a regression. So we have to start thinking, and if we have to think of resources of where we want to put most of our money into, it's practically on the prevention of the pre-cancer if we're thinking of secondary prevention. And obviously, now that we know that there's a vaccine, then we should be thinking of vaccination, obviously, for the future. But my talk today is basically about screening and treatment. Vaccination is the way to go for sure, but I think there's a lot of efforts that have to be done, and especially if countries have not even started vaccinating, unfortunately, in many less developed countries. And this is the same natural history images. This is just for references, because we're going to talk about HPV testing, but if we're thinking of pap smear or VIA, VIA is visual inspection with acetic acid, where you put basically vinegar on the cervix, and if it changes into something that's aceto-white or white, that's a positive. And this is an example of a bigger lesion, and the same you can see the changes in the cells, and obviously at the end what's invasive cancer. But now that we know what causes HPV, we're thinking on like what works best for secondary prevention screening, which would be HPV testing compared to this other two. So if we think of cervical cancer programs, there's three things we think about. It's coverage, the quality of the test that you're using, and do you actually manage the women that screen positive. So from a study that was done a few years ago, when we started to see this problem in El Salvador, we knew that the coverage was reported between 19 and 47%. So if we look at that problem, we had the lowest coverage of screening in Latin America, basically. If we know how good our test is, the quality, we don't have studies in El Salvador, but there's a study that's been published that showed that the PAP was under 60% sensitivity, the same thing with the VIA. And this is another graph that Dr. Murillo used in that publication, which showed the cumulative incidence of mortality if you wouldn't do anything with in a population, you would do no screening. The best scenario is if you would screen everyone and then treat all the ones that are abnormal. And the one that followed that was interesting to see. It's 50% coverage and 100% follow-up versus 100% coverage and 50% follow-up. So basically what this tells you is it doesn't matter if you screen everyone if you can't provide the follow-up of the abnormal ones, right? So that's the three components that you have to think of. And going back to the ideal to the reality, in a small project that we had, we identified in our health records, we want to see what's the follow-up of women after 1 year of having an abnormal result. So this is the reality, right? This is what the information system told us. That's the reality that we had to go through to try to figure out how many we would find. And then our sample size, we could not even get there. There were no charts found. A lot of the women were not properly diagnosed. And that's me a few years back. Not happy over, I remember the holidays at the end of the year, trying to look file by file and trying to find this women and physically, where they were at the time. And what we saw was that less than 50% of women that had received an abnormal PAP, or a high-grade PAP actually, had not received their treatment after a year. So and the reasons why, it's because they had not received the appointment through the colposcopy, or they had not even received their results. So if you remember the three things that I said, what's the coverage? Worst coverage in the region. What's the quality? Who knows what the sensitivity of our PAP is? And what's our follow-up? And we're talking that it's less than 50%. That equals cervical cancer being the #1 cause of mortality due to cancer in women. So at that time, we're trying to figure out what's the best thing to do. So the VIA, remember that I told you about putting like the vinegar and seeing the changes, and then you could treat it with cryotherapy. This is a great image. I remember when we did our first supervision, and these are women from the community in the rural area, and this woman is carrying a tank for cryotherapy, nitrous oxide, and this woman actually got a lesion, and she got treated with cryotherapy. So for us, this was like it meant a lot, because it meant that we were reaching the women through this alternative screening method. But in reality, if we want to think of population-based, we realized that it was very hard to scale because this needed a lot of training, a lot of quality control. So we were really concerned on like, what are we gonna do? Because there's all these problems about the fact that you need to train people to do this in a proper way and to have a good quality control. So at that time, back in 2009, we were working on the WHO guidelines for cryotherapy, and we were at the PATH office, and that's when we learned that there was a test that was going to come out that was called the CARE HPV test. It was a test that was developed in collaboration of PATH, the Bill and Melinda Gates Foundation, and QIAGEN. So basically, this is the equipment. It has a heater and shaker, it has a luminometer, and it has a control panel, and that equipment literally can fit on this area. It doesn't need air conditioning, doesn't need water, and it's very practical. In about 4 hours, you can get your batching results of 90 tests, and it's very simple to use. So when we knew that this test was going to come out and that it was going to be available, we met with the Minister of Health. So in 2009, that was in March, in 2009, we had our meeting with the Vice Minister of Health, and we told her, would you be interested? We explained all the benefits of switching to an HPV test. And then in February of 2010, we met with the Minister of Health, and we told her, as you can see, we were donating cryotherapy units at the time for the VIA that we were doing. It's like, would you be interested if we would have the possibility of doing HPV testing and being part of this? And they confirmed that, and it was reaffirmed in this document from a meeting in June in 2010, where the government said in the next 2 to 5 years, they would do an implementation and introduction of HPV testing in the country. So at the IPV meeting in International Papillomavirus meeting in 2010, basically when they were saying like we were going to launch this program to donate tests, we were there with the Ministry of Health officials saying like, we really want this. So we were like one of the first countries, El Salvador and Rwanda were the first 2 countries to get this donation. But besides the fact of getting the test, the question was like, how are we gonna implement this? And we were looking at the evidence at the time, and it was clear that HPV primary screening was something that was gonna be a game changer, specifically if we did it with a screen and treat option. So based on that, a demonstration project was developed with the Ministry of Health, the NIH, PAHO, and different local organizations, which was a proposal that we called CAPE, which is Cervical Cancer Prevention in El Salvador. We would divide this in 3 different phases. The first phase would screen 2,000 women. Then based on the results of that phase, we would screen an additional 8,000 women. And finally, we would screen 20,000 women. All of this would happen in this part of El Salvador. El Salvador is divided in 5 regions, so this would be the Paracentral region, and we would start in 4 clinics. So basically in October of 2012, the Vice Minister launched the program. This is Miriam Krimmer, the founder of Basic Health International, a representative from the QIAGEN, and obviously the minister was there to do the launch. So basically, what we did is we were trying to compare what's the best way to actually implement this. So either you screen and you send women to colposcopy for a biopsy and treatment, or we would screen women, and if they're HPV positive, we would send them directly to receive cryotherapy. Cryotherapy is to freeze basically the cervix to treat this. So what we found in the screen and refer to colposcopy, we found at that point it was a 9.3% positivity rate. We've never known what was the prevalence. And obviously this was the first time we had any information, and this was specifically for rural areas. But what we knew at the end of 6 months, that was our cutoff point. We knew from that small study that we did, if women did not show up at 6 months, they were likely lost to follow-up. So we made our cut at 6 months. And the women that were sent to colposcopy, 68.8% of them had received their treatment, which was better than less than 50%. I mean, there was an improvement because we worked around the system. But then on the screen and treat, we had an 11.9 positivity rate, and we had 98.3% of women actually getting their treatment. So it was significantly different, right? So the great thing about doing these interventions is that we learn a lot, not just from the intervention, but since we do quality control on the biopsies, we do all of this. Another thing that we found was almost a threefold difference on the CIN2 plus pathology results. So we're thinking, well, we're sending these women to colposcopy and they're not receiving the treatment that they're supposed to get because there's a threefold difference basically on what the local pathologist is reading versus what the quality control was showing. So based on all these results, we had our colleagues from the Harvard School of Public Health to do a cost-effective analysis. And basically when they were comparing the cohort, the screen and treat versus the screen and refer, what they showed was that it was more cost-effective to screen and treat than screen and refer to colposcopy versus compared to PAP. So those were the findings, that screening with Care HPV had greater health benefits than doing it with the PAP system that we were doing. That screening every 5 years was more cost-effective than doing the PAP testing that we had in our guidelines for every 2 years. And that screening with the screen and treat was more effective and less costly than doing the colposcopy, which is sending the women. So after we do all of that, we do the research, we do that, we need to evaluate the results. Then again, you can see friends from the NIH, Julia Gage, Phil Castle, Juan Felix from USC, Jane Kim from Harvard School of Public Health, Irma Alfaro from the actual company, because this was like a public and private partnership, meeting and presenting to the minister the findings. So the minister says at that point, okay, well, let's move on and let's do the second phase, but we don't think there's enough data to say we're going to stick to just one cohort. So we go to the second phase, and we go from 4 to 8 different communities. We're always screening between the ages of 30 and 49 years of age. And now the results of the screen and refer, it drops to 41.5%. You know, basically what we saw previously. And this is just with the scale. So again, you know, when we started with a small 1,000 women, and then we scaled to the amount of women that they're supposed to be screened in their region, that's where we start to see all the difficulties in the colposcopy, because the clinic just can't handle the volume of patients that they're actually getting from this. And we had problems with pathology and many things happened. And in reality, the same with the screen and treat. I mean, it dropped to 88.2%, but that's still a lot better than less than 50%. But that's reality. As you scale, you're going to see that things are going to be more difficult, and there's going to be more loss to follow up. But I think 88% it's quite good. And as far as the pathology, we found instead of a threefold, a twofold difference. So on the amount of CIN3s that were diagnosed. So, you know, there was improvement in many areas, not perfect, but, you know, it's what we could do. Now with these findings, we go back to the cost effectiveness side and the models. And now it's clear that the screen and treat has a better impact on the modeling for the cancer reduction as well as the cost effectiveness. So now the findings are that it's always less costly to do the HPV testing versus the PAP, that it's more effective and less costly to do it every 5 years. And now we find that it's very cost effective intervention to do compared to the others. So now we have our own results. So now we have our own evidence. So now we can actually justify change. You know, this is something that as a country we had never had any information about our situation, and now we can do that. So then we go into a process of negotiation, which is tedious, hard, stressful, because people, you know, one of the biggest challenges is people don't like change. And I like this picture because here we have, this is a colposcopist, this is a pathologist, this is an epidemiologist, and this is an administrator person. And, you know, they're looking at the evidence, and I think it's very clear that we have to go with the screen and treat option for our setting. But to tell that to the pathologist and the colposcopist, it was completely against, everything that they do. But I think it once you have the evidence and it's very clear and there's political will, things happen and things changed, and they understood. So now we have new guidelines for the country, and the guidelines now show the primary testing with HPV, and if it's positive, you send for treatment if they're eligible and treatable for cancer. Now that you have the guidelines to back you up and support you, there has to be a transition phase, right? And I brought an example of things that you have to account for as you're transitioning, because everything changes, how you're going to report things on your system, the paperwork. So this is the what we used to have as a PAP form, and this is the head of planification at the ministry, and these are all the cytologists that actually work for the Ministry of Health in a meeting. And they were very upset, because what are we going to do, right? We've been doing this forever, and now you're talking about HPV testing. And it's really hard, but they also understood. Our guidelines now were modified, so women 30 to 59 would get their HPV test, and women from 20 to 29 will get the PAP, and over 59 will also get their PAP. So we explained that they would still have a job, because that was their concern at the time. But we were changing everything, and this is how the new forms actually look. It's not all around just what the cytologist wanted, but it's more about variables that we need to use for the program and for the monitoring and evaluation. And specifically in our case now, there's a part specifically for HPV testing, whether it's positive, negative, the date that it was presented, and what was done as far as referral of the positives. So this is an example of paperwork, and this is the other thing. We're talking about a change in technology, but this is about actually a change in the program, because this is like a fresh start, and that's what we told everyone. Because when we start, there's like 1,000 excuses. No, that doesn't work. No, we've done something, and it's like, look, this is not about a new test. This is about a new opportunity to make a difference in the programs that we have. So this is an example of how we would follow up on the results of women that would have a pap smear back in the day, and this turned into a formal paper-based document that would help for monitoring and evaluation. So just like this, all this paperwork. The whole program has to change. So this is like an images, what it actually means to change your whole system, just for a small part of the program. But it's part of this transition. Besides that, throughout the years, a lot has to do with the advocacy, educating, working with other stakeholders. This is a very early on picture of us giving some TV, radio interviews. This is Kathleen Schmiller from MD Anderson. We set up a breakfast for people in the media so they would understand about the disease and they would talk about it. And this is Mona Soraya from CDC, the local PAHO representative and the minister, as they were disseminating the guidelines. For World Cancer Day, we set up in 2016 a symposium where a lot of this was actually more education and dissemination of the work that we have done. And the last phase, now we know, because of the evidence, the guidelines that we're going to take up to the whole regional level. So we went from those 2 to 4 to 8 health units, then to over 50 units all over the paracentral region. We increased the range from 30 to 59, and we now know that everything is a screen and treat. And then we had to set up different, what we called triage centers at the time, where women that would be HPV positive would come in to receive their treatment with cryotherapy. So that led to a lot of work, a lot of training. This is an example of training for women for the physicians that would provide the treatment. And to do this implementation, we would have to train over 3,000 people on just natural history of the disease, because a lot of the people that worked at the Ministry of Health were not aware of the natural history of the disease. We would talk about them, obviously the paperwork that has to be changed. And what we found was with the final phase, we had about 12% positivity rate, and about 88% of women actually went to their visual triage for treatment. Also, this is a slide from the Ministry of Health that just shows how all the legal framework needs to be changed around. So it's not about just thinking, when you start a program, you just have to think ahead a lot. And part of it is like legally, in our case, were the guidelines, but they also worked on a cancer prevention program, because you can't, in a lot of places, you won't be able to do this if there's not proper legal backup for it. And finally, this is an idea of how many people needed to be trained for the paracentral region, and this is what was planned in the ideal world on how we would actually scale up. And in all reality, in 2018, we're gonna jump from here to here. This did not happen. This is how we planned it, but in the real world, procurement process has been very complicated. But this is where we're actually going to be in a couple of months. We're going to start, hopefully by the third quarter of this year, we're going to have coverage in like 80% of El Salvador with primary HPV testing. So as we look into this, there's a lot of problems that happen, and we just have to think on innovation and always trying to find the solution. So we might be on the translation to practice sort of phase, and then we have to go back to the bench in many situations and figure out how we can fix problems. With all the different centers where this needs to be treated, now there's a new technology of colposcopy that I was talking to you, that it's adapted to a cell phone basically, and it has an app, and you can use those images. And what's really exciting about this that might actually change how we do screening with cervical cancer is that now with artificial intelligence, they're trying to figure out if algorithms can actually tell you whether it's a high-grade disease or not just from the image. And preliminary data says that it's actually very, very promising. We had a lot of problems with the technology, with the cryotherapy. So we did some bench testing to figure out how this was working on the field in real life. And basically what we saw, based on, we did a study with some ballistic gel and some help with a few engineers, and it was that the treatment was suboptimal in a lot of them. And after maintenance, it increased significantly. So things that people were not thinking of, and they're doing their programs. And I asked them, when's the last time you did maintenance to your gun? And they're like, no, they don't need, because they're freezing. But in reality, that's not the case. So that's something that we saw that's really important. And of course, the development of new technologies. This is Miriam. She has a UH3 grant to develop what was the cryopen, which is a gasless-based cryotherapy. It's electricity-based. So no need to carry this tank, because now this could be something portable that could run basically on electricity. And our colleagues from Rice and MD Anderson, they have an R01 where they can use something that's called high resolution microendoscopy, and they could see like in real time whether it's a CIN2, 3, or if there's even cancer. And this is what we're doing in El Salvador at the Cancer Institute in El Salvador. This was the first image that we got, and this is what you would see as a normal result, and this is what you would see if it's abnormal, and the algorithm will tell you whether it's positive or not. So another exciting thing is, since we're talking about HPV based, but there's a problem because sometimes the tests can be very expensive. There's another test that's being developed, like a paper based, like a test that could actually cost less than $2, that we're also working with Rice University. So it's very, very exciting things. Now, another problem that we have in El Salvador, and it has nothing to do with the program or the test, is the violence in our country. I'm sure that if you Google El Salvador, you'll see crime rates and mortality, and it's really bad. But it got to the point that for our studies, we needed to randomize where we would go for the safety of our research assistants based on the amount of murders that had happened in the last 5 years per area. And we offered self-sampling for women that were reluctant to screening. And what we found was basically that over 90% of women accepted that as an option. So these were women that had more than 5 years of not being screened or had never been screened, and most of them accepted this modality as an option. Another option, we just finished this pilot study, is for another underserved population, which is transgender men. We worked with the Transgender Men Association in El Salvador to do this pilot and develop educational material for them. So they would get screened, and we did this small pilot. We got 24 people to be involved, and these are the results, basically with a 13% positivity rate, and we found a 1 CIN3 case that we're actually trying to do some quality control on that. But the thing is, if you encounter a problem or there's a barrier, you have to think, how am I going to solve this problem as you go? So going back to what's ideal, practical, and real, just have in mind that there's another very important thing, and it is you have to have certain expectations. You know, there's so much that you can do depending on the setting, on the resources that you have, that, you know, you can't go across the board and say like, oh, because somebody else did it, you know, I can do it. It realistically, it's very different. And going back to every country is different, and there's different resources, right? Like I can't compare one country to another because, you know, each one is developed and has different resources. So there's always going to be challenges. Not all countries have the same financial or human technical resources. We need to understand how research can actually impact the decision making, because a lot of countries don't have any research. That's why they can't make their own decisions. So we have to see our findings, react, and work on solutions as quickly as possible, but never give up, because things go wrong all the time. I mean, all the time. And when there's very limited resources, you have to be very creative. Learn from the mistakes, and that will lead definitely to success. So I kind of showed you different things, you know, from the political will, the evidence, the research, how we negotiated, the budget, legal framework, everything. So I think the two pillars of everything is that there has to be strong political will and there has to be very strong evidence. And that's basically that's the model. That's how it's called. It's preventable, because it talks about all these different approaches that people should think about. And this is sort of a more formal way of trying to illustrate that, with political will and the evidence being the pillars. And then as primary drivers have the research and evaluation, and then the secondary drivers are all the ones that you see down there. And finally, I just want to thank all our collaborators and advisors that have worked with us, and obviously our BHI team and the Ministry of Health. And none of this is possible in a low and middle income country without the help of international agents and academia. And hopefully I can add the UAB logo soon in this as part of different collaborations that we're doing to try to prevent cervical cancer.